Today we have a very distinguished group of individuals, and it was very important to us that we got all views of our industry. And so we have asked a provider, a payer, Dr. Blatt, and a CEO startup to give a conversation about mHealth. To introduce the speakers, on the far left, we have Rich Novak, who is the General Manager of the Southeast for Cigna. We have Arman Sharafshahi, who's the President and CEO of Accelarad. And then we have Strosnider, Director of Business Technology Planning at Kaiser. So let's kick us off. So for the first question, I would ask that every panelist please give their input on it. And for those who haven't introduced themselves, please, we'd love to hear a little bit more about you and your background and your passion for mHealth. So, as Marc had just mentioned, we sort of are moving to the world of value-based services and patient-centered care. Most experts agree that care coordination is a center part of it. And so he had mentioned patients in medical homes. So at WellStar, we are, along with Northside and Emory, are kicking a few of those off. So we are looking at patient referrals, we are looking at performance tracking, we're looking at care management. mHealth is not part of our strategy at all. So the question I have for you is mHealth a necessary component of care coordination, or simply just another tool in the bag to push us through reform?
I'll start. Go for it. Can everybody hear me okay? Yeah. All right, so I'm Rich Novak. I'm the President General Manager for the Mid-South market for Cigna. Short answer is I got everything from Atlanta to Memphis and south except for Florida because I don't like the topography down there. So it's just too flat for me. You know, part of my passion here or interest in mHealth is that of the 10 billion cell phones that somebody said we're going to have by whatever date, my 3 teenagers are going to have 5 billion of those within our household, so I need to know what goes on. The answer to the question is not an easy one. Relative to helping to coordinate care, I think that mHealth is just getting started. If there's something that can be said or a stage of prior to infancy, I think that's where it is. I think that people in the audience need to understand that mHealth represents a systemic, massive shift in the business model of the healthcare institution as it exists today. And that's not hyperbole. It's massive. Okay? If you start to think about how WellStar, Emory, Piedmont, Tenet, HCA, whomever it is, how do these large systems make money today? Where do they derive their margins? It's from visits. It's from throughput. And if you change the nature of that throughput, you're endangering the business model that has gotten them to where they are. And where they are is a place where they're out acquiring physician practices at breakneck pace in the Atlanta market. And there's a bidding war that's going on today. If you're a primary care doc in Atlanta today, Chip knows this very well. If you're a primary care doc in Atlanta today and you've got a really good practice, you're sitting on a gold mine. Because WellStar wants to buy you, and Emory wants to buy you, and Piedmont wants to buy you, and Northside wants to buy you, and Tenet wants to buy you. You know why? Because you got a lot of throughput, and you can drive patients to those facilities for all sorts of things. So for me, this is a systemic change. This is a big to-do. And when it gets its foothold, somebody will make the decision that I got to change my business model because if I don't do this, somebody else will. And when they do, I'm going to get crushed. So they're going to have to find a way to transition over time. The other thing I would tell you is mHealth today, though, for the most part, is really, you know, from my perspective, has been much more oriented around consumer tools. You know, person's in the doctor's office, the doc says, you know, I think you're a little nuts, I want to give you some Thorazine. Okay, well, let me whip out my phone and, hey, you know, there's a generic for that. I can get the generic for a lot less money. Can we do that instead? Those sorts of things. Or where's the closest doc? Or how do I get there? Or what's the health grade star rating system? Things like that. What I would tell you is that You know, a lot of people think that that's kind of simple Simon stuff. It's not to the average consumer of healthcare. So when we sell to employers of all shapes and sizes and geographies, these things are a big deal. These are tools that employees want, and they want to know that they're ready and available and instantaneous in nature. So Cigna's very proud of its tools. No advertisement for us. In fact, I'll tell you point blank, Aetna's got the best mobile tools in the industry, the entire industry. So they seem to have really hit the mark for some of those things. Consumers are looking for that stuff, and more consumers are going to start looking for that because there's going to be more consumers in the system in about 98 days or whatever the number is. Okay? At least that's the theory. So, you know, assuming they're there and they get in, there are people that are going to want to know this stuff. People who have never accessed healthcare before. And maybe people who have accessed it before, but not through the insurance mechanism. So I don't want to take all the time.
Okay, I guess I'll go next. And to kind of reiterate the question, is mHealth just an add-on, or is it kind of a fundamental shift or a necessary ingredient to changes in healthcare? I want to take a little bit different approach to the previous responder here. And you know, from my perspective, I'm one of the co-founders of Accelarad. We're a medical image sharing platform. So we're a tool that's designed to help care coordination, and we obviously are looking at that from a perspective of how do we reduce the cost of healthcare, how do we reduce utilization at the right points in the care cycle. And you know, for us, mobile applications have been really another screen that we can take advantage of that's ubiquitous, that everybody always has with them, that can, you know, be there when the physician needs to access certain kinds of data at the right time. And you know, I'll take an example. Out of the 18% of the GDP that we, you know, spend every year on healthcare, a significant percentage of that, as we pointed out, could be saved, or in a lot of cases it's wasted. And one example that I'm familiar with is repeat exams. And this is happening to the tune of about $10 billion a year. All of us are getting, you know, excessive radiation, getting scanned over and over again for things that have already been diagnosed or you know, scanned before, and that's a significant amount of money that's being spent on, you know, wasted you know, diagnostic procedures. So one specific case of that that's actually very, very significant for us is in a situation where trauma transfers are occurring. So say a patient is in a car accident and gets, you know, taken by ambulance to a community hospital, and the physician that's treating the patient there in the ED doesn't know whether this patient can be treated there or if they need to be shipped to a level 1 trauma center, for example, where maybe a neurosurgeon is on you know, staff at night, let's say. And so today, in most cases, what would happen is this patient is put on a helicopter or an ambulance, is driven to the next place with the CD taped to their chest. And you know, in a lot of cases, when the patient arrives at the other end, that CD doesn't work, and its data is corrupted, and the doctor there can't access it, and a lot of time gets spent trying to figure out what to do with that data. And in the meantime, the patient is, you know, degrading in their health condition, and this data should have already been there. So better access to data can save, you know, tangible dollars. And in a lot of cases, in those transfer scenarios, that patient is sent right back to radiology and scanned by CT again because they can't waste time messing around with the CD. So our technology, just to kind of tie this back to what we do, you know, helps transfer this data before the patient ever leaves the other facility. A surgeon or a specialist at the other side can provide the triage information. In a lot of cases, that patient should never be transferred. In a lot of cases, they can prepare the OR by the time the patient gets there. They can have the proper treatment prepared. So, but how does that surgeon quickly get access to that data? It's through a mobile application. So yes, they could have seen it on a PC screen. They could have seen it on a diagnostic quality monitor, but in our case, you know, we've made available a tool that lets that doctor pull it up instantaneously anywhere they are on an iPhone or an iPad, and they can provide very rapid triage and therefore, you know, reduce the risk of you know, delays, repeat exams, and wasted dollars in the healthcare system. So, you know, I do think it is a dramatic fundamental shift, but at the end of the day, it's really just the tip of the iceberg. I think what's behind the mobile app, it's a user interface to a cloud of, you know, back-end systems that really are kind of at play that make that mobile app do what it can do. It is not just the mobile app itself, it's really part of the larger ecosystem.
So, again, restating the question, is mHealth a necessary part of healthcare going forward and reforming, basically? I'm here from Kaiser to answer as a resounding yes. First of all, in full disclosure, we're an early adopter of Accelarad. We're also an early adopter of an EMR, the largest civilian deployed EMR in the world. I've been challenged by our PMGs, the Permanente medical groups, to do something that's kind of revolutionary, to put together a program, an integrated program, to figure out how to deliver 60% of the care at home by 2016. If you can't figure it out, healthcare is a bricks and mortar intensive business. You got to build a lot of hospitals. Look at WellStar's growth. Their building plans, $800 million over the next year or two for health parks. Look at Kaiser's last 2 years. We've went from 15 medical office buildings to 30. We're done. We have the capacity now to probably even double our membership and have that same throughput, but we don't want that throughput. We want to treat patients where they want to be treated, when they want to be treated. You've got pigs on planes checking their progressive auto insurance. We laugh, but guess what? I flew in from Washington this afternoon. There are people doing that on the plane. So why can't they chat with their advice nurse? That's one of the technologies I rolled out this year, advice nurse chat. The workforce changes, the office of the workforce changes. We're kind of in cube farms now. You don't want to be on the phone calling, saying your child's at home at 101 fever with a runny nose because your office mate might be calling the Department of Community Services and having you arrested. So you want to be chatting with that on the nurse and saying, do I need to get out of work now and take them in? Or do I need to have maybe a telemedicine unit at their school and have a checkup done that way? Some of that will be coming. And I leave you with one other vision. A member, we call them members, they become patients, unfortunately, sometimes. But let's say this member is a 7-month, a female, pregnant 7 months. She would normally have to go in for a pretty thorough exam and a check because she's near term. That would probably require her either going into another Kaiser facility or a large MOB that might be kind of far away from her home. Atlanta traffic's horrible. She has other children. Just doesn't want to do it. God forbid she puts off that visit because you could find something. Many of them are rushed to delivery quickly just via that visit. Well, in this case, she sits down, she turns on her TV. It happens to be cable TV. There's a channel there that she hits. Her OBGYN's waiting for that appointment. She's sitting in her living room. Also waiting on that appointment is a dietitian, let's see, her PCP or primary care physician, and the midwife that's going to probably be in the delivery center when she delivers. So she has that 7-month checkup from her living room. And you saw patient-centered medical home that talks about care continuum and handoffs. Well, the people that I just talked about are those handoffs. They just joined this virtual visit in her home over her TV. Why do I say TV and not PC? 3 months ago, I was saying, use VIDYO or VIDYO, yeah, technology because it's secure, it's this, that, or the other thing. It's for PCs and tablets. Well, we did a quick look at our member demographics. 75% of our members have PCs. Fewer have tablets. About that have smartphones. 93% have cable TV. Cable TV gives you the bandwidth to do that kind of stuff. They're also comfortable with it. It gives you the high def you're requiring, the high definition screens and things like that. So I'm proposing to skip the PC route. Tablets, yes. Phones, yes. But for that really intense multi-specialty care visit that can be done at home, even with peripherals, just think about, look at the consumer devices that are out there. When I talk connected health, I give a long connected health talk. I'm wearing a jawbone up. Very basic, steps, my sleep pattern, stuff like that. I can get that. I can download that to my iPhone, and I can send that to my EMR. My care team can see it if they care to. That's another thing us IT folks have to kind of pull the reins in on. We need to go to our docs, we need to go to our clinicians and say, what do you need, when do you need it? because we can get it for you, but we also run the risk of getting them too much information, believe it or not, an information glut. Or you've heard the term alarm fatigues. We could be setting ourselves up for that. So we're also doing some tracks that are saying, okay, in the certain chronic diseases, onset, control, whatever's after control, which is good, out of control, basically. What do you need? Do you need weight? Do you need pulse? Do you need steps? What data do you need to know that that patient's either getting better or getting worse? Worse means an intervention. Better means send them a Whole Foods gift certificate and tell them to go shopping because they're doing fantastic. That's where we're headed. I think that's also the future of healthcare. I can tell you that's what I was talking about on the Hill this week. Although they wanted to talk about Obamacare, I wanted to talk technology. It was very interesting.
You know, I began by saying healthcare is in a bubble. And because of that bubble and that extraordinary cost, it's going to drive extraordinary innovation. I would submit to you that the TV is a PC. The TV is an IP device. How many of you have Netflix already embedded in your TV? It's an IP device, right? I mean, you're streaming right to the TV. It's not an analog device anymore. It's just a big PC, if you will. And the PC and the tablet and the phone has become a computer. It's actually annoying to make a call on it. And most people who use smartphones, about 12% of what they do on it is make a call. It's a handheld computer. So again, what operating system doesn't matter as much. But when all of a sudden you see Google and Apple enter that market, I'm going to tell you going forward, maybe your healthcare provider is Amazon. And maybe that's going to blow both of these guys out of the water completely. Okay, and Google just announced they're going back into the healthcare business. And all right, so let's start to imagine this slightly different and more empowered, and why that model, with going to the doctor who's sitting there waiting for you to show up, is like the 19th century business model. Okay, you as a consumer want to access care, and I'll again say it's great if you're homebound and you're sitting in the house and you got your TV, but you know what? Most of us ain't homebound, so I want to access care wherever I am, whenever I am. Me, I'm a road warrior. I want to access it from the hotel room. I'm out at 2 o'clock in the morning in whatever city I'm in, or whatever part of the planet I'm on. Okay? So now let's give you a slightly different vision of the DICOM and the disc. I get that teleradiology study, but you know what? I actually went on to MRI, eBay of America, and I said, who has an MRI machine that they'll offer me up for my MRI order? And it turns out that the local hospital isn't using it at 4 a.m., so if you want to come in at 4 a.m., we'll give you an MRI for $50. How many of us have got on red eyes at 6 o'clock in the morning that you woke up at 3 for, and you get a better price because it's got 2 connections at 6 in the morning instead of that civilized flight at 10 o'clock that's a direct connection? All right, the difference can be enormous, $300 versus $1,000. We do that. All right, so now I got the MRI for $50 from MRI of America. All right, so now I put the out there, back on there, and I said, who wants to read my MRI? Okay, these guys have already concatenated most of teleradiology into a couple of viewing centers. I don't need radiology there. Hell, I don't need dermatology, orthopedics, or half the people there. I'll walk into a telepresence room, and my ology departments are virtual at this point. They're not physically located. And the doctor could be in Hawaii, right? Well, you know what? He could also be in Bangalore. And he's willing to read my MRI for $30. Now I just got one done for $70. Do I really care what Cigna says if I'm approved or not? Am I really going to wait for 2 weeks to hear from this guy? Do I have approval? No. You're going to go direct. That's the revolution. I'm going to disintermediate the insurance company, which is why you already heard him saying Aetna is turning into an information company with CarePass and iTriage and offering you IT tools to better manage it. They're not going to be indemnification because I'm going to find cheaper ways to deliver care directly to me. And if I have to go to a physical building, all right, you can do that. That'll be $100 out of your pocket, fine parking, fine traffic, or push the button. Do whatever you want. So care is going to virtualize. It's going to go to the lowest cost provider with the highest quality. And I'm going to have TripAdvisor for healthcare. How many of you use TripAdvisor? Well, come on, you plan trips, you look out there? Well, all right, 10 years ago, TripAdvisor had 3 reviews. Now it's got 50, 100. I don't go anywhere as a corporate hotel where I'm probably not going to look up what TripAdvisor says about the Marriott I book in, Mumbai. It doesn't matter where I'm going. So now I'm going to find out about that doctor. Maybe I go to Health Grades. Right now it's got 4 reviews. Give it 5 years. It's going to have 4,000 reviews, and you're not going to be able to hide. You're going to find out the best doc. And you know what? If he's in Bangalore and the US says it's illegal because he's not licensed, but he's going to give me care, maybe I take it. He trained at Oxford. He trained at the best schools in the nations. The last thought I'll leave you with here is telemedicine and state licensure. Well, if I can cross borders, and I'm assuming the physiology in Georgia maybe is not too different than Mississippi, maybe it's different than New York, but who knows, all right? But assuming that you actually behave physiologically in a similar manner, why isn't the doctor in New York licensed to treat you? Well, if medicine becomes virtual, it's no longer local. Now we got that crazy thing called the Commerce Clause. So I will go break the state licensure based on the Commerce Clause, because I'll basically say the states can't regulate it because it's not local commerce, it's interstate commerce. That's exactly what the banks did when Citibank wanted to open up a bank system to do back-end credit card processing in North Dakota. Interstate commerce, the Commerce Clause allowed them to move away from community banking. It's coming.
And thank you so much. And I know we are running on low in time, so I'm going to ask a few rapid questions to the panelists. And I first want to start with Chip. So much of consumers, when you think of mHealth, it's about apps. And Richard talked about functionality. With you being at Kaiser, being one of the most integrated systems in the world, and for the doctors and clinicians in the room, how truly effective is mHealth today clinically? A lot of times we're talking about virtual visits and that kind of stuff. Where is it actually changing people's lives in terms of health? Where is it today, and where will it be in 2 years?
Today, I tend to think it's where Richard said, it's in its infancy. But we're envisioning a day when you go to the doctor, if you have to go to the doctor, or you have a virtual visit, and he or she is inputting into the EMR, a fairly ubiquitous EMR that has liquid data, if you will, can be shared across all other platforms, and they prescribe an app. They simply push you an app. Or the patient, we're seeing more and more patients coming in showing our doctors, look at how many steps I'm doing, look at how many steps I'm averaging. That changes the conversation. Okay, they're in the office, that's not really what we needed. We could have taken an email to do that, and we would have written back, the care team would have written back, fantastic, you're averaging 9,000 steps, try to push it to 11,000. That's really cool. These are consumer devices. We're seeing a lot of that walking in the door. Withings with their Bluetooth scales and the blood pressure cuffs. Now, we do have some clinical sites that'll say, well, we need to make sure that's a certified device and blah, blah, blah. Well, the reality is it's empowering the patients to, to start to take, that's the holy grail, right? We want patients to take ownership of their own health and not just be a pill generation. I'm sick, I'm going to go to the doctor, get a pill, and be healed. That's not what we want. And we're seeing it across all generations, too. I get a lot of pushback saying this will never be adopted by certain generations or certain demographics. I can show you studies that say they're flat out wrong. So we're seeing it now. We're actually starting to design it in our workflows. We're blowing up workflows to totally change them. In quite a few specialties right here in Georgia and Mid-Atlantic. But I see within 2 years, the acceleration in the adoption is unbelievable. And especially when our docs are calling me saying, hey, so-and-so downloaded this app, a patient, they're using it. Should I be looking at this data? Should I be recommending this app to other patients? I tell them they have to make that call. If it's valuable information to them, they should really consider it.
I think that leads a great point. Has my next question for Arman. So both of you have mentioned earlier that mHealth is offering an easier way for care and likely will be a very disruptive move away from doctor-directed care. We're already seeing this. Among consumers, it says of mHealth services, 59% say they have replaced some in-person doctor visits already. In fact, 42% of doctors worry that mHealth will make their patients too independent. So the question is, for Arman, for your perspective, selling both to doctors and patients, should doctors feel threatened by this new mHealth trend?
Yeah, I don't think most doctors probably feel threatened because they see the writing on the wall. I mean, the adoption of mobile devices is probably unequaled in the history of technology as far as iPads and iPhones and other mobile devices that have been adopted. So I think they know that this is inevitable. I think the majority of physicians realize that there's tremendous value in contiguous monitoring of patient conditions, whether that's diabetics or any chronic conditions where constant sensory data can be extracted from patients carrying certain devices. Those kinds of things can keep patients out of the ER, out of readmissions to the hospital. Another scenario that I'm familiar with is patients, hospitals are trying to get the patients out of the hospital, so they're trying to keep the patients at home and have home care nurses, for example, take, for example, in my case, pictures of the patient, be able to upload those instantly up to the hospital's own information systems, and the doctor can centrally sit and view patient records without having those patients necessarily coming into the hospital. I think all of these types of clinical applications, doctors definitely see the value in terms of improving quality of care, convenience for patients, convenience for themselves. I'm not sure whether there's a group of doctors that maybe feel threatened, but overall, I think the value is unquestionable.
Great. Switching gears a little, let's talk about the business case. And this question is directed to Rich. Some out there would argue that the widespread mHealth adoption requires services that appeal to payers and not the patients. Patients, they argue, are very highly sensitive to price and have a sense of entitlement to their healthcare services. As a result, people say that healthcare payers will be there to underwrite mHealth as a broader change in healthcare. Do you agree with this statement that IT vendors must concentrate their focus on the payers and not on the payers' problems, not the consumers?
In the short term, the answer to that question is yes. I do agree with that. So if you take a look at the research around healthcare and the way people purchase it and how they get it through their employer, or not even through their employer, just the individual market, and even the government-funded programs, right? The one thing we all have in common is that we're Americans. We have a certain culture around everything, especially healthcare. You know what that culture is? I want it. I want it now. I want to pay as little as possible. And I want it to be 100% correct 100% of the time. So the talk about people wanting to pay extra over and above for a tool that might help them find the right doc or find a high quality doc or get to the right place at the right time or do something on a virtual basis. No, I think at the outset, I don't think people will pay extra for that over and above whatever insurance or federal program mechanism that they happen to be enrolled in. That said, it's not as though there isn't a market for that, because if you take a look at, most people probably in this room, you have no clue what your health insurance benefits costing your employer. No clue whatsoever, unless they're divulging that to you. But for an extra half a point, 50 basis points, maybe 80 basis points of what they're paying, you could probably add on 25, 26 apps that, on their own at the Apple Store or the Google Store or whatever store are costing very little. So if you market to carriers or other vendors that are in the marketplace, whether it doesn't have to be medical coverage companies, it can be pharmacy benefit managers too. If you market or to the exchanges themselves even, when you market to them, you're talking about a small fractional percentage that gets lost in the overall mix, and then just becomes part of their package, right? The problem then is, now it's part of their package. You're never going to take it away. So you start to get into more of a consumer retail-oriented environment, which is where we're heading. We're not going to get there overnight, but we are heading there. Different people with different packages and taking stuff in and putting stuff out becomes very problematic. So, for me, there's a huge cultural perspective that's in play for a lot of these things.
Great. The last question I'll ask is of Marc, and then I'll open up for 10 minutes to the audience for questions. Will there be a big difference on how mHealth technologies will be used and developed by a major health system versus a small PCP office? You saw the ability to connect, but there are differences. And a lot of times we see that the large systems are the ones who can pay for these large connections and ability to connect. Do you think this will hold true for the small PCP office?
I think it's possible, quote, the small PCP office, the way we think about it, goes away. I mean, I started out as a family doc because I wanted to be Marcus Welby. I think I made the mistake of telling the American Academy of Family Docs Marcus Welby was dead. I probably shouldn't have been that harsh. But, you know, it's a 1960s business model. It doesn't make any sense. It costs too much. So as far as where it's going to come, and disruption starts from below. Disruption starts with those annoying patients that you don't want, that you're really thrilled somebody else is seeing. Those are the ones I'm going to go after. I'm going to move up that value chain, and by the time I eat your lunch, it's too late for you to stop me. So how might this start? Any of you heard of a company called American Well? I know you guys have. All of you have. So American Well is a company out there that will offer you a visit with your primary care doc or a specialist for somewhere between 20 and 40 bucks. They started in Hawaii, again, interestingly enough, again, because transportation's an issue to get to Oahu to get to see a doc. So immediately, the Hawaiian State Medical Society sued them for practicing without a license and tried to throw up a roadblock. You can't make this stuff up. Within 2 weeks, the legislature in Hawaii convenes, passes a law, and says it's legal. Hell with your docs, okay? It's better for the citizens. So now American Well is in Massachusetts, Minnesota. It's winning state contracts. They will offer you direct care for the state employees to access a PCP or a specialist. And again, 20 to 40 bucks. No co-insurance. It's what it already cost you to see him. So it's completely disrupting his business model and his business model. It's direct to consumer. It's empowering you. So now the next question is, you need your data. Now thank God Google stepped up. We're going to go get your data. We're going to force it to be given to you because we're going to pass basically laws that says, you know what, it's your data. That's part of Meaningful Use Part 2. How do you empower the patients and give them data? Now, unfortunately, it says you got to show it with 5% of your patients and you got to give it to them within 30 days. Pardon me, but that's crap. You can quote me. Eventually, it goes to the patient. It's your data. You paid for it. It's yours. So I think, and American Well, by the way, is one of about 40 companies that are beginning grassroots all over the country in different venues, like Teladoc, on, that are looking to give you direct care, IM, chat, interactive voice response, a PC, or through your television. It's not going to matter. They're going to come at you with low-cost, quality care, and you're going to own the data, and you're going to be empowered to figure out where you go. Bricks and mortar goes away. Maybe the value of an IDN diminishes, doesn't go away. I still, gunshot wounds, trauma, I still need hospitals, but much less.
So I want to add something to that, to build on what Marc is saying. So, we people in this room, we tend to think about things relative to the healthcare delivery system in Atlanta, because we live in Atlanta. But you take a company like American Well, and you put that in not just Macon and Augusta, but what about places like Cohutta, Georgia? Anybody ever been to Cohutta? I've been to Cohutta, not much in Cohutta, right? Milledgeville, Calhoun, right? These smaller towns where, the primary care doctor is the guy who's coming from Macon or from Augusta 1 or 2 days a week, or Sandersville, where there's one primary care practice, and they're overwhelmed with Medicaid patients. Overwhelmed. I know those docs. They're excellent physicians. These companies, okay, are disruptive in certain areas, and they are incredibly supplemental in others. And for me, like for our business, we actually find this to be extremely, extremely helpful, and something that we're hoping takes a hold and gets out into those places.
Thank you very much. Now it's your turn. Any questions? Yes.
In terms of mHealth, we run the stroke center at Northside and St. Joseph's, and we do telemedicine in about 15 different states and also internationally. We're finding that the biggest barrier to telehealth is government regulations itself, in terms of state licensing, things like that. It takes us 3 to 6 months to get licensed in a new state. So these are some of the barriers that occur. How can we get the government to speed up and keep up with some of this technology and save some lives?
There's a law right now that was just reintroduced, the 2012 telehealth law. So you're nodding, so you know it. It takes away those barriers where the clinician is It's credentialed is where that's it, that's all they need. And incidentally, if you're DOD or former DOD, that's the VA model too, right? I mean, once they've got a medical license, a doc in the VA can go anywhere in the CONUS and Hawaii and Alaska, and same with pharmacists. And that's something that we didn't even touch. You touched briefly, I think. We're going to be suffering a huge PCP and physician shortage coming up. Pharmacists, we're turning out a lot of schools right here in Georgia, turning out a lot of highly credentialed pharmacists. I think their scope of practice is going to start to look somewhat like it does in South America and Europe, where they're the doc in Milledgeville, believe it or not. They're the one prescribing the fairly routine antibiotics for the flu and things like that.
You know, I kind of alluded to it a little bit when I talked about licensure. I actually, about 6 years ago, sitting at ATA, had the privilege of sitting down with Newt Gingrich talking about this to the Enterprise Institute. And one of the things he was very interested in was national security. And I pointed out that during a disaster like 9/11, when the towers went down, all the people that came in to try to help, if they weren't licensed in New York, were violating law and could have been sued for practicing. There weren't a lot of casualties, as we know, so there wasn't a lot of need for acute care. But the government's plan during a national disaster was to activate people from the military reservation and move out military docks. Now, as soon as you get off the reservation, you're practicing without a license. So I suggested to Newt, what if the Secretary of Health could declare a national emergency, and under very specific conditions, you could suspend state licensure for the point of the, oh, okay, that would be the nose of the camel under the tent, and that would start the process of actually going for national licensure. Nurses pretty much have it under blue sky laws. They can practice anywhere. I think you see it coming. And the really intriguing part is not just where you're doing it. What happens when a low-cost provider in India wants to start offering stroke care?
Guatemala.
Yeah, or anywhere. We put the bandwidth in place, you know, when Level 3 and Enron and all those people went bankrupt, that's how we transferred services to India, okay? The cable's in the ground, the fiber's there. I can do this, and I can do it across a continent, I can do it across an ocean.
Currently, I think wireless companies, they do have a lot of network, and they own the network, and they own the devices, right? So the wireless companies, they are coming up with APIs, which basically enables the big companies and small companies to expose their APIs, and they even offer a lot of services like mHealth and voice conversion and a lot of other APIs. For example, currently when a patient goes to doctor writes a prescription, and the patient has to come to the Walgreens or CVS and then give that slip to the representative, and the patient has to wait for 10-15 minutes to fill that prescription. So the API is coming out, so basically the patient doesn't need to wait until that time. So as soon as the doctor is writing a prescription, they even read the prescription, and the APIs that are exposed from the wireless networks, they take that input and then deliver that to the Walgreens and other areas. So how is that going to play in mHealth?
You know, at the end of the day, again, I think it comes back to the patient owns the data. The patient owns the right to interact and do things any way they want. So I think when the doctor transmits the electronic prescription, there's the SureScripts network, obviously, right now. It's integrated tightly to almost every EMR that's out there. It's got high levels of security. It used to be kind of ACT, no ACT, but now it's got utilization review, formulary review, on and on and on. Tons of capabilities to improve the clinical decision support of the doctor making that decision. Generic substitutions, and then eventually, it'll be integrated into genomic pharmacoprofiles. So I'll actually know your pharmacoprofile, and I won't prescribe that SSRI. I'll prescribe the right one for you based on your profile. That's coming within 5 years. So who's going to own the profile? Where's that profile going to sit? Maybe I want to bounce the e-prescribing app off your smartphone where you have your genomic profile, have that interrogate the smartphone, come back to the doctor, enter it in EMR, and the doctor never sees your genomic profile because I don't want that in the doctor, or I want that on my phone. I want that in my space. I don't want to share certain stuff. Maybe you want it out there. It's going to be your choice. And I bet everything I just said, everyone will choose slightly differently to do it. But going forward, self-empowerment is going to be critical. You're not going to stop moving everything to online. Again, it's cost. We're rational economic consumers in this country. We're going to look for lower cost, and healthcare has reached a pain point where it's become unaffordable for most of us.
They're going to have to change the prescribing laws as well.
Yes.
From state to state.
Or you see a grassroots movement that actually starts, again, some of the states have turned around and said reimportation works for our state employees. Have INS stop it at the border. INS is not looking to stop amoxicillin or, chlorthalidone coming in across the border. It's not, they don't care.
Well, thank you very much. That concludes our event tonight. Please give a large round of applause for that.
Before you guys get away, I wanted to give you a token of our gratitude for coming this evening. Thank you so much. Appreciate it.
Thank you.
Thanks a lot.
One brief announcement. Traveler's going to be doing a door prize for us. Jenny here in the purple dress has a bowl for business cards. So you have not given her your business card yet. You have a couple minutes to do so before they do the drawing. I know it's a little tight, but try and get those in. Just wanted to speak briefly about our event sponsors this evening. Both Verizon Wireless and Travelers Insurance were interested enough to sponsor the event for the evening. Also wanted to note that we have a number of sponsorship opportunities available, both within Tag Health at the gold, silver, bronze, and Friends of Tag level. We also have sponsorship opportunities available for the Health IT Leadership Summit that was spoken about earlier at the gold, silver, and bronze levels as well. So if you have interest in those, it's great exposure for your companies. Lots of ability to get access and exposure to the health IT community. As you can see this meeting, the attendees we have here and the number of companies, it's just a really good way to get involved. With that said, I'd like to invite Nathan Martin, Managing Director of Travelers Technology of the Southern Region, to take a few minutes to speak about Travelers, and then we'll do the drawing.
I'll make it short because I know everybody's time here has been well spent. And again, my name is Nathan Martin. I'm with Travelers Insurance, and I'm not here to fix your computer, believe it or not. So that's one of the things everybody always looks at is Travelers Technology. So what do you do? And that was the number one question that we saw or I heard when I was out there is, why are you guys interested here? And I'll tell you is that one is a learning opportunity for us. We spend a lot of time in the medical field in underwriting medical devices and then also IT products. So from the standpoint, Lauren Thompson's here. She's our medical device underwriter that's here locally. And we also spend a lot of time educating others about what's going on in the community so that we can help provide the insurance products that your companies need. And that's for your workers' comp and property and stuff like that, but we do not sell direct to anybody here in this audience. So, it's really for us to be able to just be a resource for everybody. And so look for Jenny, she's around here a good bit. And, as far as active with the TAG community. So I really appreciate everybody's time and letting us be a sponsor. So thank you very much.
Let's see who wins the door prize this evening.
What is the door prize? Well, the beautiful Lauren Thompson has made a wonderful gift basket, and it's equipped with lots of stuff. You can use it on the golf course. Of course, there's an umbrella. That goes without saying. There's some water bottles in there. Just a lot of little different things. The tote is actually for ladies, so gentlemen, please pass the tote on. But all the other things are unisex. So take advantage of it, and we hope you guys enjoy.
So our winner tonight is Don Vance of Tescom.
Thank all of you for being here. Thank our sponsors. We really appreciate them. We wouldn't be here if we didn't have sponsors. We will see you November the 12th at the Health IT Leadership Summit at the Fox. Have a good evening.